The venous flow in the lower extremity moves from caudal, from the foot to the heart, in the superficial and deep system. In the superficial system, it drains into the deep system across via the junctions and perforators. All this hemodynamics are controlled by the valvular system inside the veins. So any problem or any leakage in this valve cause transmission of the high pressure venous flow in the deep system to the superficial, causing the superficial vein to dilate and become varicose veins. The main cause of varicose vein in lower extremity and the most important cause is saphenous incompetence or insufficiency. It is either due to junctional, to reflux in the saphenofemoral junction along the thigh or the whole lower limb, or preterminal valvular reflux with competent saphenofemoral junction. So what about the management? It's either medical treatment like lifestyle adaptation, compression of stockings and drugs. Surgery is outdated because of have many complications and very high recurrence rates. Nowadays, the most convenient treatment option is endovenous ablation, like thermal ablation, thermal tumescent treatments like radiofrequency, laser, and microwave, or non-thermal, non-tumescent ablations like ultrasound-guided foam therapy, mechanochemical ablation, MOCA, or glue ablation. So what's our role of ultrasounds? Pre-interventional assessment, inter-procedure guidance, and follow-up assessment. Now we talk about thermal ablations. The intraoperative procedures, we firstly do Vin Access, ultrasound-guided, catheter navigation, initial tip positioning, tumescent anesthesia infiltration, and final tip positioning, then confirmation of study. Short video. Before we start, we don't know, it's a local anesthetic procedure. We inject a small pleb of local anesthesia at the side of Vin Access. Then we start ultrasound guidance. Here we use ultrasound to guide the needle to puncture the saphenous vein. When we're sure we have a blood backflow from the needle, we start inserting the guiding wire. Here we are in. We insert the guiding wire. When we are sure we are inside the vein by ultrasound, we remove the needle and insert the introducing sheath. Then we start the most important step in thermal ablation. It's a tumescent anesthesia infiltration. What is tumescent anesthesia? Placement of large volumes of diluted anesthesia in the perivascular position under the direction of Doppler's guidance. It serves several purposes. Protects the perivascular tissue from heat injury. It decreases the diameter of the treated vein to ensure good ablation and reduces the pain. So it's totally a painless procedure. It's an outpatient procedure. We use diluted lidocaine. Here's the composition of the intermittent anesthesia. The average amount of fluid is from 8 to 10 milliliter per centimeter of vein. Here's the way we use ultrasound to inject the tumescent perivenous around saphenous vein. Here we pierce the superficial fascia and inject fluid in the saphenous compartment. When we reach the terminal part of saphenous vein at the saphenofemoral junction, we must inject a large amount of tumescent, especially deep to the saphenous vein, to prevent heat injury to the common femoral vein, which is a deep vein. Then we position the catheter. The catheter of the thermal ablation or heating must be away from the deep vein of the saphenofemoral junction by at least 2 centimeters to prevent heat injury to the common femoral vein, the deep vein, to prevent the DVT. We will talk about different modalities. First of all, the radiofrequency ablation. It heats the vein to 120 degrees centigrade. Here's the catheter, the closed-fast catheter. It's a segmental ablation. We heat 7 centimeter by 7 centimeter, as I'm showing here in this video. Here's the catheter placement inside the vein. Then we ablate the vein 7 centimeter by 7 centimeter for 20-second intervals. We call it the segmental ablation. We do excellent compression on the site of ablation to ensure total coaptation of the venous wall to the catheter, to the ablation catheter. What about laser? Laser is a high energy induced transmural vein wall injury. The heat may reach about 1000 degrees centigrade. We have different wavelengths, either hemoglobin specific or water specific. The hemoglobin specific we use in a bare fiber catheter, while the water specific, we recently use water specific. It decreases the perforation and reduce the post-operative pain. Here's the application of the laser catheter, the laser tip. Here's the radial tip catheter. We connect it to the machine to ensure that the laser light is on. Then we introduce the catheter inside the vein as usual. We adjust the parameters of the machine and start ablation. You can see here in the ultrasound image, there is vaporization and boiling of the vein, as you can see here in this image, with no perforation and no injury to the perivenous tissue. Here's the radial fiber needle. You can see the light in the patient while we are ablating. The microwave catheter, the same introducing procedure. Ablation is very short segment. It's a 1 centimeter, and we ablate 1 centimeter by 1 centimeter, as you can see here. After this, we do a post-ablation compression. Follow-up, we found the total occlusion of the saphenous vein, sparing the saphenofemoral junction, prevention of DVT, and in the axial image, you can see total obliteration of the vein. Early follow-up after one week, you can see here no competent saphenofemoral junction with no reflux while performing Valsalva maneuver. And this, on the right side image, you can see loss of compressibility, denoting total obliteration of the vein. Long-term follow-up, you can see here the sparing saphenous junction, total fibrosis and disappearance of the saphenous vein in the fascia. And while performing color duplex ultrasound, no reflux is noted. So according to the European College of Phlebology guidelines dated 2020, the overall success rate of the RFA is equivalent to the EVLA, the laser ablation, about 98%. Success. It's a paper have published me and my colleagues. According to the long-term ablation, we found that the recanalization rate is about 11%. Complication rate very minimal. We have a bruising and tenderness more in the laser ablations. Here's the patient after ablation. Total disappearance of the varicoses in the lower extremity. What about non-thermal ablation? We'll talk about ultrasound guided foam sclerotherapy. It's a very easy maneuver. We mix a sclerosing material like polydecanol or STS with air in a technique called the Tessari technique, three-way stopcock, two syringes. The gas to liquid ratio is 4:1. We mix it to create foam. This appearance of the foam. The setting for this an outpatient procedure. We done it in office, in your office. It's a very simple maneuver. Use ultrasound to guide the needle puncturing the great saphenous vein. Here we access the vein, start injection of the foam. The foam is very white inside the vein. It causes spasm and obliteration of the vein. It's a very simple and low cost, but the occlusion rate is very questionable. It's less than thermal ablation. It's about 25% less than thermal ablation. It have no severe complication. Here's the technique I have recently adopted by injecting the foam through the introducing sheaths. After applying tumescent anesthesia, the tumescent anesthesia compresses the vein to reduce the size. I prepare the foam here now, then start injecting the foam inside the sheaths after performing tumescent anesthesia. Now you can see the propagation of the foam inside the vein in the ultrasound image. We inject segment by segment. You can see the propagation of the foam. The nice in this picture that the foam runs in the tributaries, as you can see on the top of the picture. So we obliterate also the tributaries, not the saphenous vein. We fill the saphenous vein by foam. Do compression as usual. So this paper published by Kaffas informed us that the occlusion rate by this newly developed technique 100% after 1 month, 94% after 1 year, and 90% after 3 years. The patient resolved from this. No major complication. The only unfortunate complication is hyperpigmentation, and it resolves after 3 to 6 months. newly techniques like mechanochemical. It's a caster delivered foam sclerotherapy, but in the this type of caster have rotating microblades. It causes injury of the intima inside the vein and spasm the vein to ensure more effect of the sclerosing material. It's have a very high occlusion rates. The very recent now we use glue. There are 1 minute. There are different providers of this glue: the American glue, Vinacil, and the Turkish glue, Vinblock and Venex. We inject glue via caster and saphenous vein, doing compression to seal the vein from inside. It's non-tumescent. It's a very easy procedure. Short video showing this procedure. It takes about 5 to 3 minutes. We insert. Let's run through this video. We insert the caster as usual. Then we prepare the glue gun. We start to inject the glue while rapid pulling up the caster, because the Turkish glue is very high polymerization rate, so it seals in very short seconds the vein inside. Here's total ablation of the vein. It have 95% success rate, but they have a very unfortunate complication or side effect. Some patients have insensitivity effect to the glue, so it causes redness and hotness. The only treatment is removal of the vein surgically, so it's a very adverse side effect to this glue. So according to the European College of Phlebology, the recommendations for different ablation techniques, they recommend endovenous thermal ablation as a first-line treatment of saphenous vein incompetence by level of evidence class 1A, while level of evidence in by MOCA and glue is less. In MOCA level A class 2B, while in glue is level A 2A. So we conclude in the last 20 years, endovenous ablation procedures have become the most frequently used therapy for saphenous vein, for treatment of saphenous vein. It's such minimally invasive techniques meet the demands of cosmetically superior, less invasive, and more successful treatment modalities. The endovenous thermal ablations is considered the first treatment option for truncal varicose vein. No significant difference between thermal ablation procedures. While non-thermal ablations are effective at thermal ablation, but they are still questionable about the long-term results. Thank you for your attention.